Hello everyone. Today I am here again with one more lecture for the PDCET 2026 candidates. This is last minute revision part 2. So, we will go through these slides fastly so that you can revise more and more important topics from which MCQs can be asked. Uh, let's start with this. So, first one is table on neonatal jaundice. So, mainly difference between physiological and pathological jaundice. Physiological jaundice onset is more than 24 hours. If it's less than 24 hours, then it's most likely to be pathological. Peak for physiological around 3 to 5 days, while early rapid rise that is less than 24 hours is pathological. Bilirubin is usually less than 15, while in pathological it's more than 15. Duration less than 7 days, while pathological jaundice can persist for more than 14 days, and type physiological is always unconjugated, while pathological is often conjugated. So this is the difference. Now dehydration, mental status for some and severe dehydration mainly. Mental status irritable in some while lethargic in severe. Eyes sunken in some, very sunken. Thirst. Some dehydration patient will drink eagerly while if the patient is severely dehydrated, he is lethargic, so unable to drink. And skin pinch is low in some dehydration while it's very slow in severe dehydration. Hereditary hyperbilirubinemia mainly of four types: Gilbert syndrome, Krigler-Najjar syndrome. These two are of unconjugated type, and Gilbert is mild while Krigler-Najjar is severe. Dubin-Johnson and Rotter syndrome are of conjugated type, and black liver in Dubin-Johnson syndrome and no pigmentation in Rotter syndrome. Now, microcytic anemia. So, it can be seen in iron deficiency, thalassemia, or chronic disease. Iron deficiency, the key finding is ferritin is decreased in thalassemia, increase RBC count, and in chronic disease, increase ferritin. So in thalassemia, mostly we look for Menzer index. It's important. You can rule out even difference between thalassemia and iron deficiency anemia. So Menzer index is MCV, mean corpuscular volume upon RBC. So if RBC count increases in thalassemia, there is compensatory RBC hyperplasia. So as RBC count increases, MCV is low in both thalassemia as well as iron deficiency anemia. So when RBC count increases and the denominator increases, the overall value decreases. So Men's index is less than 13 in thalassemia because RBC count is more in thalassemia, while it is more than 13 in iron deficiency anemia. So this is the differentiating point. Now nephrotic versus nephritic, we have seen yesterday also. So proteinuria is massive, more than 3 3.5 gram per day in nephrotic, while it's mild in nephritic. Hematuria is present in nephritic. Edema is severe in nephrotic because of severe proteinuria. BP is normal in nephrotic, while it's decreasing hypertension is seen in nephritic syndrome. And cast, fatty cast in nephrotic, while RBC cast in nephritic. Cyanotic versus acyanotic CSG. Cyanotic CSG shunt is right to left. Acyanotic it's left to right shunt. So right to left shunt. So on the pumping part of the heart, which pumps blood to the whole body, it receives the unoxygenated blood. Example: TOF VSG cyanosis is present in cyanotics and accidental cyanotic. Exanthematous disease. Few important features of these disease: measles, Koplik spots, scarlet fever, strawberry tongue, erythema infectiosum, left cheek appearance. Important MCQs have been asked previously. Left cheek appearance is seen in erythema infectiosum and rosella infantile fever, followed by rash. IEM urine order: phenylketonuria, musty order, maple syrup urine disease, maple syrup, and isovaleric acidemia, sweaty feet order. Developmental milestones: now social smile at 6 weeks, head control at 3 months, sitting at 6 months, and walking at 12 months. Vitamin deficiencies: vitamin A deficiency causes night blindness, vitamin D causes rickets, C deficiency causes scurvy, B1 beriberi, dry and wet, and B3 pellagra, diarrhea, dermatitis, dementia, and fourth D is death. So 4D of pellagra and vitamin K deficiency leads to bleeding. Primitive reflexes: when they disappears, morose at around 6 months, fruiting around 4 months, palm grasp around 6 months, and plantar crest around 1 year. ORS versus Resumel, we have already seen Yesterday, ORS sodium is 75. Mainly the difference is low sodium content is there. Potassium is 20. Liquid polyethylene ORS is high in Resomel, and ORS is used mainly in normal children while Resomel is used in severely malnourished children. Now, radiology part, bubble signs and conditions, single bubble in pyloric stenosis, double bubble in duodenal atresia, and triple bubble in jejunal atresia. Short stature familial versus constitutional. Bone age is normal in familial, while it is delayed in constitutional. Puberty is normal in familial, it's delayed in constitutional. And final height is short in familial, while it's normal in constitutional. Because the parental height is also short in familial, so the final height is short. Now, neonatal respiratory disorders, RDS, surfactant deficiency, we will go to RDS, respiratory distress syndrome, transient tachypnea of newborn, and meconium aspiration. So, what are the causes? Surfactant deficiency in RDS, delayed lung fluid clearance in TTN, and meconium aspiration. Onset at birth within 6 hours and at birth. And preterm, more common for RDS, term C-section for TTN, and because of delayed fluid clearance and post-term meconium aspiration. X-ray ground glass appearance in RDS, hyperinflation in TTN, and patchy infiltrates in meconium. And course RDS is severe. TTN is usually self-limited, gets resolved in 48 to 72 hours after birth, and it's variable in meconium aspiration. Torch infection, toxoplasmosis. Key feature is intracranial calcification, which is of diffuse type. Syphilis, snuffles, rubella, patent ductus arteriosus, cataract, CMV. Again, important one, periventricular calcification is seen in herpes infection may leads to vesicles. Leukemia, ALL and AML. So age for ALL common in children, AML in adults. Or rods is seen in AML. Prognosis is poor in AML, and common type for ALL is lymphoid, and for AML it is myeloid. Now, meningitis CSF findings for bacterial, viral, and tuberculosis. Cells neutrophilic in bacterial, lymphocytic in viral, and lymphocytic in TB. Protein is largely increased in bacterial. It's mild elevation seen in viral and elevated in TB, but more uh, highly elevated in bacterial. Glucose is decreased. It's less than two-thirds or less than half of the corresponding RBS in bacterial, normal in viral, and decrease in TB. Opening pressure is more in bacterial, normal in viral, and more in TB. Metabolic acidosis type, high NN gap metabolic acidosis. If you ask for examples, DK in lactic acidosis, while normal NN gap metabolic acidosis, it's in diarrhea and RTA. So high anion gap metabolic acidosis is seen in these two types, and normal anion gap metabolic acidosis, that is NAGMA, is seen in diarrhea and RTA, irritable acidosis. Inheritance pattern of few important disease, Duchenne muscular dystrophy is X-linked recessive, cystic fibrosis is autosomal recessive, Marfan syndrome is autosomal dominant. Most of the biochemical illnesses are autosomal recessive. So next is cause for acute flaccid paralysis, Guillain-Barré syndrome, ascending paralysis is seen, poliomyelitis used to be asymmetric, and transverse myelitis sensory level is seen. The patient will complain of a certain sensory level, like this is patient trunk and limbs, so he will complain that there is sensory demarcation, that below this level he is uh, feeling numbness. So sensory level is seen in transverse myelitis. The murmur types, pansystolic in VSD, ejection systolic ESM and ASD, and continuous murmur in PDA. Glycogen storage disorders, Bronch's disease, glucose 6 phosphatase deficiency, and clinical features severe hypoglycemic episodes, Pompe's disease, acid maltase deficiency, cardiomegaly seen, myocardial disease, muscle phosphorylase deficiency, and exercise intolerance is seen in muscle disease. Absence seizures, brief steering look, EEG, feature of absence seizures is 3 Hz spike in wave pattern. So this is important for absence seizures. Drug of choice for absence seizures is ethosuximide. It's not available, then we can give valproate. Tonic-clonic, generalized myoclonic sudden jerk-like movements, and atonic means drop attacks. Electrolyte imbalance, hyperkalemia, what ECG findings are seen? Peak T waves, hypokalemia U waves, hypocalcemia prolonged QT interval, and hypercalcemia short QT interval. Neurocutaneous syndrome, neurofibromatosis type 1, cafe au lait spots are seen, tuberous sclerosis, Ashley spots, Lister Weber syndrome, Port-Fine stain, severe combined immunodeficiency versus D. George syndrome. D. George yesterday we have seen, catch 22 syndrome. So SCID versus D. George, T cells high, very much decrease in SCID while it's mildly decreased in D. George, and B cells is also increased in SCID while it's normal in D. George. So B cell is SCID is B plus T cell deficiency while D. George is only T cell deficiency. Cause combined effect thymic aplasia and D. George, calcium level is normal in SCID while it's hypocalcemia seen in D. George syndrome. BCG is live vaccine, OPV is live, IPV is killed, FB is recombinant. Central cyanosis due to CSG or lung disease, while peripheral cyanosis due to cold or the patient is in shock. Type of shock: hypovolemic shock is caused due to dehydration, septic shock, infection, cardiogenic shock in CSG, and distributive shock in anaphylaxis. Now, few X-ray findings, as we can see here, double bubble in duodenal atresia. So here two bubbles are seen, double bubble in duodenal atresia, and this is triple bubble, jejunal atresia, and this is the gaseous abdomen, that is uh, pneumatosis intestinalis here in NEC cases. Okay, now chest X-ray, we can see the classic boot-shaped heart. This is the boot-shaped heart, and boot-shaped heart of tetralogy of Fallot. This first is the boot-shaped one. Second is right ventricular hypertrophy, right-sided aortic arc, and pulmonary bay flat due to infundibulous pulmonary stenosis, and pulmonary oligemia is also seen in tetralogy of Fallot. So ground glass appearance in respiratory distress syndrome. Okay, hyperinflation plus streaks in transient acute of newborn, patchy infiltrates in meconium aspiration, and boot-shaped heart in tetralogy of Fallot. Now this is the EEG finding. This is hypsarrhythmia. If you look at the ECG, it's basically chaotic. Okay, so no particular rhythm or background activity is visible. So chaotic EEG is characteristics of hypsarrhythmia, and this is seen in basically infantile spasm or West syndrome. So hypsarrhythmia is seen in West syndrome. Okay, so this is calcification and periventricular calcification. This is diffuse calcification, and this is hydrocephalus. So hypsarrhythmia EG in West syndrome, periventricular calcification in cytomegalovirus infection, diffuse calcification in toxoplasmosis, and dilated ventricles is seen in hydrocephalus. Now some genotic syndromic phases, epicanthic folds, broad flat nasal bridge, slanting palpebral fissures, brush field spots seen, hypotonic open mouth, and protruding tongue. In Down syndrome. Now in Turner syndrome, short stature, height is less, narrow high arc palate, low hairline, webbed neck, important one, broad chest with widely spaced nipple, space is widely widened, and cubitus valgus deformity of elbow joint, short fourth metacarpal, congenital lymphedema, and coarctation of aorta can be seen, bicuspid aortic wall and aortic dissection, horseshoe kidneys, or streak ovaries. So these are important features of Turner syndrome. And Marfan syndrome, lens dislocation, and increased arm to height ratio, breastbone depth inwards or protrude outwards, joint hypermobility, decrease upper segment to lower segment ratio, tall and slender build, ecnodactyly, flat feet, kyphosis or scoliosis. So these are the features of Marfan syndrome. Now, epicanthic force plus flat faces in Downs, webbed neck in Turner, long limbs in Marfan, low set ears plus micrognathia in D. George syndrome. Rickets and bone changes, this is rachitic rosary, and widened epiphysis. Okay, this are the features of now. Like this is knock knee. This is bow leg. This is windswept deformity, like the windswept of any vehicle. And this is Fabry tibia. Rachitic rosary seen in rickets, wrist winding, earliest sign, bow legs, and craniotabs. So wrist winding is the finding is the earliest sign. Now, smear finding, this is something, someone, this is apple and if someone has bitten apple, so bite cells, target cells, so bite cells in G6PD deficiency, target cells in thalassemia, sickle cells in sickle cell anemia, and blast cells in ALL. Okay, so these are the blast cells, sickle cells in sickle cell anemia, target cells in thalassemia. This is like the target of archery, so target cells, and these are the bite cells. Okay, so these are the peripheral smear findings and the hematological disorders. Irrigatory syndrome, these are the cafe au lait spots, multiple spots. Sorry. So ash leaf macules, shagreen patches. So these are all the findings. So cafe au lait in neurofibromatosis type 1, ash leaf spots in tuberous sclerosis, port stain in Sturge-Weber syndrome, and shagreen patch in tuberous sclerosis. Okay. So this shagreen patch, tuberous sclerosis, ash leaf macules, and this is cafe au lait spots and port stain of. So these are the urocutaneous findings in urocutaneous disorders. Exanthemus disease skin. So this is the oral mucosa coplic spots. These small white coplic spots are seen. This is left cheek appearance. These are the lesions, polymorphic lesions of different stages. Okay, so coplic spots in measles, left cheek in erythema infectiosum, rash after fever in varicella infantum, and vesicle of different stages is seen in varicella infection. So this was a short lecture today, and I will try to cover one or two more lectures in the coming days. Today is already Thursday. You have now 2 days left. That is Friday and Saturday for your revision, and mostly on Saturday or on Friday, at least one day you have to give for traveling purpose also to reach at your center. So just few points you should remember. Stay relaxed. You have read already everything you have done, and now it's just time to revise whatever you have read. Revise it properly. You have 120 questions divided into three segments, 40, 40, and 40, and you know about the time limitations. Now, some people or some students keep on asking me that how much should we attempt. So, look, there is no such criteria. It differs for everyone, but in my opinion, a general opinion, what I always say to students that if your preparation is very well, okay. So if you are, there are two sort of students. One is well prepared, and other is moderately prepared. I'm not saying that anyone is not prepared. Okay, either you are well prepared or you are moderate prepared. If you are well prepared, you can think about the negative marking. You can think about negative marking that I should control negative marking. So you can leave 10 to 20 questions if you are having not much idea about those questions, and you can attempt 100 out of 120 if you are, but for these group of students you should be confident in these 100 questions. Okay, then you can leave the next 20 ones, or at least you are confident in 90 and you are leaving the next 30 questions, and among these 90 questions at least 80 questions you are getting corrected. Okay, so this should be the scene. But if you are moderately prepared, you are not much confident about many questions. Like suppose you are not confident about 60 questions out of 120. So is this a good thing to attempt only 60? No, not at all. Okay. In such situation, you should go for at least more than 110 questions, or in sometimes even 115 questions, because that plus minus strategy works always. Like suppose if there is one minus one third negative marking in any exam, so if you are making guess for three questions, and out of that three questions, even if one question gets corrected, or even out of four questions, three wrong and one right, and the question is of 4 marks. Okay, so you are getting plus 4 for this and minus 3 for this. So overall, your score is plus 1. And if you are leaving all these questions, then definitely your score is 0. And just keep in mind that even if you attempt 60 out of 120, then also there will be many questions in which you are going to make mistakes. Okay. So if you get correct only 50 questions, then the chance of getting selected and getting good rank is very less. So if you are well prepared, then only think about negative marking. If you are moderately prepared, then try to attempt at least more than 110 questions. This is just my opinion. It differs from person to person, from student to student, and from examiner to examiner, and from tutor to tutor. So it's not any universal law for attempting these exams, but this is my experience and this is my opinion for especially children who are moderately prepared. Okay, so thank you very much. You can comment in the comment section about if anything particular you want to revise in the next 1 or 2 days. Thank you.